Thank you. Thank you, Hillary. Welcome, everyone. And at the beginning, I'd just like to say I'm sorry that I missed our gathering. And I want to thank everyone for their outpouring of condolences and love around the death of my mom. And you can't believe how powerful and beautiful the Ayurveda and yoga community was to our family, and the most generous, the most loving, the most caring, the most supportive during a time of deep grief. And I only look forward to the day that I can give back. And so thank you to everyone, and the beauty and love just really came through, and it's helping us through a rough period. And know many of you've lost family members, and so you know where I'm coming from. So thank you. And the lecture I wanted to give tonight would have been one of the first lectures you would have had over the course of the weekend on the nervous system. And the nervous system is one of the areas of the body that I have really a lot of interest. It's unexplored, it's unique, it has incredible potential, and some really interesting pathology that some of it's unexplained. And I'm always reminded of the quote from Descartes where he said, "Cogito ergo sum," which is loosely translated, or not loosely translated, means "I think, therefore I am." And it really was a complete misconception, because Descartes thought, that this 3-pound wad of fat above our shoulders was the most important part of our bodies, and the rest of the body was essentially a carrying case for our brain. Didn't understand that the central nervous system, the brain, and the spinal cord were only part of a greater nervous system, which involved the autonomic nervous system, the enteric nervous system, and intimate relationships with every organ of the body, including the endocrine system, which many people feel is really an outgrowth of the nervous system. So what I'd like you to do, and I would have done this on the weekend, is if you could, just humor me for a couple of minutes and assume the most uncomfortable position you could assume where you're sitting right now. Sit on a foot, kneel, try and get as uncomfortable as you possibly can. And feel into the uncomfort of whatever you're doing. And close your eyes and feel the discomfort of whatever position you're in. And now I'd like you to take your right earlobe and squeeze it as hard as you can. And observe the difference in the feeling of discomfort you have from whatever you're doing now that you're squeezing your earlobe. It's so interesting that when we create a new focus with the nervous system, that we create an instantaneous adaptation. The nervous system is a fast-moving system. It can engender pain, and it can adapt to pain, and it can dissipate pain. Pain is not the only thing it does. It does many, many things. But we can create a new focus and fool our system into believing that the pain no longer exists. So by way of an introduction, every human being enters the world with a remarkably unfinished brain, a really unfinished brain. I mean, other animals are born, dolphins can swim, giraffes can stand, but we humans were helpless for years. And, most authors will say that the human brain is not completely developed until age 25. However, this seeming limitation signals one of our greatest advantages. And the reason it's a great advantage is that baby animals develop quickly because they're genetically programmed to develop quickly. In contrast, humans have developed a brain and have thrived in many environments because they haven't arrived with everything hardwired. Human brains are monitored, are changed are modified by life experiences. So we become live wired. You know, our brain's flexibility, it derives not from the growth of new cells, but how those cells are interconnected. And we know that now from imaging. You know, MRIs and DTIs can show us the interconnection of our brain at many, many different ages. A baby's neurons form at least 2 million new connections every second as they take in information. By age 2, there are over 100 trillion interconnections in a child's brain. From that age until age 25, our body and our minds and our live wiring undergoes a pruning until we're left with what we need in order to survive and thrive. Similarly, everything you've experienced thus far has altered and changed the physical characteristics of the brain. Physical structure of the brain, the physical interconnectivity of the brain. Some interesting facts about the brain. There are more cells in the human brain than in the Milky Way galaxy. And that's a picture of the Milky Way galaxy. There are 100 billion neurons. The average amount of electricity that's generated by the brain is somewhere between 15 and 24 watts per hour. So that's enough electricity to light a small incandescent light bulb. Neurons fire at a rate of approximately 328 feet per second. Now, if you think of that speed is faster than the Voyager space probe is moving into outer space. You know, it'll take it 350 years to reach the nearest star. The brain is approximately 3 pounds. It's 60% fat, mostly cholesterol. So all these myths surrounding low cholesterol diets are probably not a good idea for brain health. The brain has no pain receptors. Brain surgery can be done without deadening the brain itself. The brain, even though it's a small volume of the overall body, it needs 20% of the cardiac output of the human body. The average person has 70,000 thoughts per day. And then one of my favorite interesting fact is that when you smell or taste chocolate, it increases theta waves. And they've done MRI experimentation which shows that theta waves are the same waves that are energized during deep meditation. So sometimes I think when I'm eating chocolate, I'm in deep meditation. People think that when you drink, you forget things. What alcohol actually does, it blocks the laying down of new memories. Emotional rejection and physical pain activate the same areas of brain. And modern day computers, it takes 40 minutes for the fastest computer to simulate 1 second of human brain activity. And clearly, meditation has shown by DTI and functional MRI to increase productivity, attention span, focus, awareness, memory, creativity, and empathy. At this week's Yoga and Science Conference, Dr. Satbir Khalsa is going to talk about how after one average yoga class, the average person has increased their resilience by 20 to 30%. Changes in behavior. So what I'm saying, the brain is an amazing structure. And yes, Descartes might have been right in what he was saying, but the brain doesn't live in isolation. The brain has many interconnections. Now we can look at the brain in two functional ways. We can look at it functionally anatomic, and we can look at it functionally developmental. And you may hear developmental theories of the brain talk about 3 types of evolutionary views of the brain. What you're seeing on the screen right now is a side view of the brain, a sagittal view of the brain. This is in the midline of the brain. And the upper part here is the cerebrum. This is the cerebellum. This is the corpus callosum, and this is the pons and the brainstem coming down to the spinal cord. The evolutionary view will separate the brain into 3 sections. The first section would be the reptilian brain, the oldest brain. And that involves primarily the functional portions of the brain that deal with aggression, behavior, territoriality, ritualistic behaviors. And that involves the brainstem and the midbrain, this portion of the brain here. So this is the oldest part of the brain. This also controls the automatic functions of respiration and heart regulation. From an evolutionary view, the next brain that would be developed is the paleomammalian brain. What that involves is the limbic system, which comes out to the side of the brain adjacent to the corpus callosum here, which deals with our emotions and our sense of smell, and the cerebellum here, which has some function with reproductive behavior, parenting, and balance. The final developmental part of the brain, from an evolutionary standpoint, is the neocortex. It's all these curvilinear structures up here, the cerebral cortex. And this part of the brain allows us to do abstract learning, language, planning, perception, and discernment. So from an evolutionary standpoint, the oldest part of the brain, the reptilian brain, is the brainstem, functional. Then we come to an emotional brain, and then we become to an analytic brain. Anatomically, the brain is separated into certain lobes. And functionally, they're divided into the frontal lobe, which is separated from the parietal lobe back here by this structure here, which is known as the central sulcus. And on the front end, or the anterior surface of the central sulcus, is a structure known as the precentral gyrus. And these curvilinear kind of snake-like structures on the brain surface, these are called gyri. And the spaces in between them, the caverns, are known as sulci. So sulci are the caverns, gyri are the curvy structures on the top of the brain. You know, when they dissected Einstein's brain, you know, they were looking to see some, incredible changes in his brain in terms of his intelligence and his ability to discern and his imagination. What they found was very minimal increase in the curving of these gyri in his brain and a tiny bit more gray matter. So the central sulcus divides the front of the brain, the frontal lobe, from the parietal lobe to the back of the brain. And the function of this precentral gyrus is primarily the somatomotor cortex of the body. So a lot of your motor action is controlled here. And the postcentral gyrus, which is part of the parietal lobe, is a lot of your sensory activity here. The occipital lobe is the posterior aspect of the brain. This tongue that sticks out to the side here is known as the temporal lobe, and deep underneath the temporal lobe here is the insular cortex right there. So the frontal lobe of the brain here, you can see, controls personality, behavior, emotion, intellectual functions. And the right and left lobes are separated by the interhemispheric fissure. And while most people are taught that the right brain and left brain are functionally and significantly different in their functions, emotional versus analytic, male versus female, in patients who have an absent corpus callosum where the right and left side of the brain don't talk, that's not seen to be true. So while there may be a predominance in one or the other, it's not as dominant as we always thought it was. So the frontal lobe controls these things here. In addition, it also has the most dopamine secretion in the brain. So it controls pleasure as well as these functions. The motor control of speech is Broca's area here, and all of these areas of the brain that have names, Heschel's gyrus, Broca's area, and you'll see some of the others as we move through, have been named by Brodmann, who was a neuroscientist several decades ago, and there are 47 different functional areas of the brain. And we're not going to go through all of them. We'll just go through the most important ones. So the motor control of speech here. So if you have a stroke, that involves this area of the brain, you'll be able to think speech. You'll be able to formulate it in your head, but you won't be able to functionally make speech. So this is the motor control of speech. So if someone has a stroke and they have this expressive aphasia where they can't speak, even though they know they want to speak, they may be able to write. You know they've had a stroke in this area of the brain. The corollary to that is understanding speech is Wernicke's area, and that is in the temporal lobe, and we'll come to that in a few minutes. The next area that we just want to briefly talk about is the parietal lobe of the brain, and that includes the area of the postcentral gyrus posterior to the occipital lobe, and it controls primarily sensation. And there are areas in there which store complex memory patterns and some taste involved there. What it also does is it integrates perception to thought. It involved with touch, speech, and language processing here. And strokes in this area involve the 5 A's. You know, apraxia, which is complex movement, agnosia, which is inability to recognize or discriminate things, aslexia, which is the inability to read independent words or symbols, impossible to recognize them, acalcula, which is inability to do math, and aphasia, but not an expressive aphasia like we see here from the motor area. This is an aphasia where you cannot create speech in your mind. You can say words, but you cannot create conscious thought patterns. The occipital lobe back here is primarily the visual cortex of the brain and controls sight. And, you know, I usually ask my students, well, you know, do you need your eyes to see? And the answer to that question is, obviously, you need your eyes to see in real time. But can you see without using your eyes? And the answer to that is yes. I mean, you can see memory. So everyone close your eyes right now. Just close them tight, and envision your last vacation, wherever it was. Can you see the beach? Can you see the trees? Can you see the lake? Can you see where you were? Can you see your partner? And the answer to that is uniformly yes. So while your eyes are not functioning right now, your occipital cortex is functioning. And yes, you can see without your eyes. But the eyes are really an interesting set of organs. The left and right eye, you see in this diagram here, have certain characteristics about creating visual fields. And this is important clinically only because if a patient comes into you and says, you know, I really can't see the outside of my right eye, and you would automatically know where that abnormality would be. Or I can only see, you know, the outer parts of both my right and left eye, and you would know where an abnormality would be along that track. So anatomically, what we're looking at here is, these are the globes in the eyes, those are the lenses. Back here is the retina, and these are the optic nerves. And the optic nerves, just above the area where the pituitary sits, cross over. And a portion from the right eye goes to the left portion of the occipital lobe, and a portion from the left eye goes to the right occipital lobe. So the inner portion of the left eye goes to the right occipital lobe, and the outer portion of the right eye goes to the right. The inner portion of the right goes to the left, and the outer portion of the left goes to the left. So let's say the person comes in and says, I can't see out of my left eye, then obviously they have an abnormality here. You can see this visual field has no sight in that left eye, but complete sight in the right eye. And let's say they have had a partial stroke just involving a portion of the optic nerve before it splits. Then they would have the inner portion of the left eye and the whole right eye. The contrary would be true on the opposite side. If they had an abnormality that existed right at the center portion where the optic nerves cross over and form what's known as the optic chiasm, This is actually a very common area to have pathology because the pituitary gland lives right in this area, and tumors of the pituitary gland can grow up. And patients won't present with pituitary abnormalities. They'll say, I can only see with the inner portion of my eye because this portion of the optic nerves is being occluded by that pathology. Similarly, if we go now to the optic tracts, to the visual cortex, patients may complain with, just monocular outer vision in both eyes, and that would be, for the eyes would be the inner portions, and inner portions would be blind, and the outer portions would be visual. So by knowing where the visual field defect is, you can predict where the pathology is in the patient. Let's go back. Okay. So the temporal lobe, which is this tongue of brain that sticks out here, is really important because it involves the sensory input for memory. And it's also the storehouse for emotion. It's the primary auditory cortex, so this is where we hear. And it's the primary olfactory cortex, so this is where we smell. And there's a series of interesting tests you can do, for the olfactory and for the auditory systems. So the olfactory system, which is intimately associated with the limbic system, which is our emotional system, begins with the smell center here, which is the olfactory bulb. And then it winds its way around to this portion of the temporal lobe, which is known as the amygdala, the hippocampus region. If you notice, the olfactory nerve, which is the first cranial nerve, does not have any connection with the higher functioning brain. So then when we smell, it immediately becomes memory. Or if we smell something that has a memory factor to it, the memory will come back before we can process it. That explains why. Several things. One is you walk into a room and you smell something and you immediately think of, your grandmother's kitchen. Well, whatever that smell is, chocolate chip cookies baking, loaf of bread breaking, because the olfactory bulb is intimately attached to the hippocampus and amygdala, the memory centers of the brain, and the emotional centers of the brain. So you get a feeling well up in you. The other thing that's important about this is the area of the brain that is first affected by Alzheimer's disease, which we'll talk about in another lecture. So one of the first symptoms of Alzheimer's disease is loss of sense of smell. So you'll see in a nursing home with elderly patients, they'll say, yeah, doc, I don't feel like eating anymore. Well, the reality is that they've lost their sense of smell, which is a significant component to what taste is, and they no longer can enjoy food because sense of smell is gone. A poor man's test for that is to see if people can smell peanut butter. When you lose your sense of smelling peanut butter, you know you're in trouble. So now all of you I know are going to go run out tonight and go buy a jar of Skippy peanut butter and see if you can smell it. Or if you have one in your house, you might want to just check. The final is this deep portion of the brain, which we call the fifth lobe of the brain, which is the insular cortex. And that's involved with perception and self-awareness. It's involved with empathy. And this is the location that Dr. Ramachandran has discovered the mirror neurons of the brain. The mirror neurons are really interesting structures. They're the neurons that allow us to feel with someone. On Sunday was the 15th anniversary of 9/11, and I was watching NBC, and they replayed the images of the planes crashing into the World Trade Center, and I can feel the same emotion I felt 15 years ago. I could feel the sadness people felt. You can feel the sadness of the people. You see a child crying, You could feel my sadness when my mom passed away. Mirror neurons allow us to feel that. That's our interconnection with each other, and that's how we build our empathy. The temporal lobe and the insular cortex also are involved with hearing, and hearing is a really intricate and beautiful process. But I forgot one thing. The insular cortex is also the part of the brain that is intimately associated with addictions. And what they found that in addicts who have strokes in their insular cortex, their addiction disappears. And how that works, we really don't know. It's one of those mysteries. But, you know, the addictions and the cravings disappear. This is the cross-sectional view of the ear. And the nerve that goes to the temporal lobe is the 8th cranial nerve here, which is the vestibular cochlear nerve. The vestibular cochlear nerve, vestibule and cochlear. So there's a portion that controls balance and a portion that controls hearing here. It's interesting that in cancers of this nerve, they most commonly occur on the balance side of the nerve. However, people always present with deafness because it presses on the auditory side of the nerve. So a patient will come into you and say, you know, I'm losing my hearing. You know, how can we assess for hearing loss? Well, hearing is via 2 ways. It's either through the air coming in here that hits your tympanic membrane and causes vibration of these little bones. This is the auditory ossicles, the hammer, anvil, and stapes. And just, you know, a trivial pursuit thing, the smallest muscle in the body is the stapedius muscle, which holds onto the stapes here, adjacent to the semicircular canals. And this augments the sound and transmits it to the 8th cranial nerve. Also sound, since these are bones, and since this is attached to your calvarium, sound is transmitted through the bone as well. So how much sound is transmitted through the bone and how much sound is transmitted through the air? It varies in people, it varies in the thickness of the bone, but primarily 60 to 70% of sound should be traveling through the air, and about 30 to 40% of your sound travels through the bone. So if a patient comes in and says, you know, I can't hear, and you want to determine, is it a anatomic hearing abnormality or is it, you know, a neural hearing abnormality? And I've had many patients my Lyme disease population, who have, you know, vata derangement involving their vestibular cochlear nerve, where their deafness is related or their tinnitus is related to neural pathologies. We can easily test for that. And the test is using a tuning fork. And what we do is you hit the tuning fork and you listen to it at the meatus, okay, right after you strike it. Then you hit the tuning fork again and you place it on your mastoid bone, okay? If you hear it louder when you listen to the meatus and the patient says they're hard of hearing, their hearing is going down, then you know it's neurological. If it's louder when you hear it along the bone, then you know it's conductive. It's related to the structures in here. The bones have gotten hard, they're arthritic, the tympanic membrane has broken down. So again, if it's louder when you listen to the meatus and the patient is going deaf, then you know it's nervous. If it's louder when you have it against the bone, then you know it's conductive. So that's just a quick and easy test, because vata oftentimes can present aggravated in the sensory neural hearing loss pathology, particularly in patients who have Lyme disease. Tinnitus and hearing loss is a common complication with that, and you might want to evaluate them. And while I think it's not one of our compliances, you know, with NAMA, it's just kind of an easy, quick test. So that's vestibular cochlear hearing. The cerebellum is literally little brain. So the cerebellum is this part of the brain, the second evolutionary portion of the brain to develop. And its function is coordination of movement, equilibrium, posture. It's divided into two hemispheres. You can see here, this is the up-down view, a right and a left hemisphere. And the central portion of it is known as the vermis. And the vermis is called vermis because it looks like a little snake, a little worm. And it's the first part of the brain to be affected by alcohol. So when patients lose their balance and lose their coordination, this is the portion of the brain that's affected by alcohol, you know, in those old, you know, tests that they used to do. The brainstem, which involves the pons, which is this structure here, this little ball. When the word pons from the Latin means bridge, because it's the bridge from the upper brain and the spinal cord, and that controls sleep, involuntary functions like respiration, and involuntary cardiac activity, regulation of the heart rate. There's a pathology that we'll look at as part of our dementia and Alzheimer's that involves the pons. It's called central pontine myelinolysis, which has an interesting presentation and very typical, very easy to treat once you recognize its abnormality. The medulla, which is coming down from the pons into the spinal cord, coordinates the involuntary functions. So this creates them, this coordinates them. It also involves vomiting and manages blood pressure. There are sensors in here, in this part of the medulla, that measure the level of bicarbonate in your blood, which is essentially expired air. It determines whether or not you have to breathe deeply and whether or not you need more oxygen. Other important structures that we should talk about are these structures in here. You can see this darker area adjacent to this kind of even darker area centrally here, and a slightly grayer area here. These are the areas known as the basal ganglia and the thalamus. And those are really important structures because they control movement. They process information between the two hemispheres. They involve amplitude and speed of motion. And it also involves a portion of emotion. At the level of the brainstem, I put this cross section in here because I think it's important. This is the brainstem at the level of just below the pons. So this is the cerebral aqueduct. And this structure here, which you see is very dark, is the area known as the substantia nigra. Second to the cortex, this is the most dopamine abundant portion of the brain, and this is the area of the brain that becomes defective in Parkinson's disease and Parkinson-like syndromes. What happens here is the granules that contain the dopamine that coordinates and relaxes motion become depleted, and there's no longer any coordination of motion, and you end up with those athetotic motions that you'll see, repetitive motions that you'll see in Parkinson's disease. So the substantia nigra, this is the area of the brain that becomes deficient and diseased in Parkinson's disease. It's also important to note that the brain is covered with certain important surfaces. First is the outer layer, which is the skin, and then you have your calvarium or your skull. And the calvarium is made up of multiple different bones. The frontal bone, the parietal bone, the sphenoid bone, the occipital bone, temporal bone. And these are interconnected here. You can see this little cleft by sutures, which means they're sewed together like sutras. And for many years, we thought that these were fused, but we were wrong. They are not fused. Craniosacral therapists can demonstrate, and using imaging studies, that you can move the calvarium and change the integrity of the underlying surfaces of the brain, both for good and for bad. But for therapeutic reasons, you can move the calvarium and shift the shape of the bones. Deep to the calvarium is the structure known as the dura mater. And dura mater means hard mother. And because it's a hard mother, it's kind of thick and rough and forms a protective coating around the brain. Just deep to that is the arachnoid, and it's called arachnoid because it looks like a spider's web. And deep to that is the pia mater, which is known as the soft mother, because it's very soft and pliable, and that's directly applied to the brain. It's directly applied to the brain. So there are 3 layers of tissue that surround the brain. And you'll hear terms about pathology involving these areas of brain. Anything that's above the dura, between the dura and the cranium, is known as the epidural space. And that's just a potential space. So an epidural hemorrhage, an epidural infection, an epidural abscess would live in this space here. And those are, generally speaking, medical emergencies and very dangerous. Because in order to separate the dura from the bone, it has to be under fairly high pressure. If something is considered a subdural, below the dura, that's between the dura and the arachnoid here. And that generally is not in medical emergencies. You may have heard of subdural hematomas, subdural collections. Those are, generally speaking, low pressure events and not much to worry about. Anything that would exist underneath the arachnoid would be called subarachnoid. And notoriously, subarachnoid hemorrhages are, generally speaking, impending causes of death because they are oftentimes the result of an aneurysm that is ruptured in the brain. So we have the subdural, epidural space, subarachnoid space. There's no subpial space because they're in the brain tissue. So these 3 layers of tissues are known as the meninges, or the coverings of the brain. You may have heard of meningiomas. Well, those are tumors that would arise from these tissues of the brain. These little cauliflower-like structures that you see sticking up here arise from the arachnoid cells, and they fill these blood pool spaces here known as dural sinuses, dura, sinuses, space. And what they do is they drain the fluid that surrounds the brain and put the fluid back into the circulation. So those arachnoids, the arachnoid granulations, are part of the fluid balance structure of the brain, also known as the ventricular system. And the ventricular system is made up of 3 major ventricles: the lateral ventricles, which have a frontal horn, an occipital horn, and a temporal horn. This temporal horn, imagine it coming out towards you or away from you. So these lateral horns are connected to this structure here, which looks like a bird's head, through the foramen of Monroe, the interventricular foramen. This is the 3rd ventricle. And the little eye of the bird, the top of the beak, and the back of the beak are 3 of the 4 joining structures between both lobes of the brain. This is the anterior commissure. This is known as the massa intermedia, which connects the 2 thalami to each other. This is the posterior commissure. The 4th connecting pathway between 2 hemispheres is known as the corpus callosum. This 3rd ventricle then travels down through this long structure, which is known as the aqueduct of Sylvius, to this portion here, which is known as the 4th ventricle. And the 4th ventricle has 2 apertures, one that comes out to the back, which is the foramen of Magendie, and one that comes out to the side, which is the foramen of Luschka, so lateral side foramen of Magendie. And this is the area where the cerebral spinal fluid, which is produced inside these ventricles, is elaborated out and is allowed to circulate around the brain and down along the spinal cord. So these openings are here down in the 4th ventricle. Cerebral spinal fluid, this fluid, is made in all the ventricles. The largest area it's made is in these lateral ventricles, which have these structures within them that produce the fluid. So cerebral spinal fluid is made in the ventricles, then flows out, and then bathes around the surfaces of the brain and the spinal cord. What's important about this is that if there's an obstruction to the flow of the cerebral spinal fluid, or there's too much production of the cerebral spinal fluid by these little cauliflower-like structures in the brain known as the choroid plexi, you can develop syndromes related to too much fluid, which is known as hydrocephalus. And hydrocephalus can present in many different ways. The most common presentation is mental status change. And in elderly patients, if you're working them up for dementia and Alzheimer's disease, one syndrome that you need to consider to be sure that they don't have is a normal pressure hydrocephalus, which is the result of inappropriate reabsorption of the cerebral spinal fluid. Okay, we'll skip that one. I want to run quickly through the vascular structures of the brain because that's going to be important when we talk about stroke syndromes. The brain is supplied by two major circulations, the internal carotid circulation and the vertebral basilar circulation. So the internal carotid circulation is the primary circulation to the brain, and it comes through the neck, front part of the neck. The vertebral basilar system is a secondary, smaller circulation to the back parts of the brain, and it comes along the spinal cord, spinal vertebral bodies actually, and enters the brain through the foramen magnum, which is the back part of the brain here. These two circulations in most patients form a joining and supply the brain with ample blood flow. The cerebral circulation from the carotid artery has three major branches. The middle cerebral artery, which has two divisions, a smaller third in the Sylvian fissure, and the anterior cerebral artery, which you see coming up here. This location right here, the junction between the middle cerebral artery and the internal carotid artery, is the most common location for aneurysms of the brain. So patients who present with aneurysms of the brain will present with diseases related to this area of the brain. Also, hemorrhages of the brain, hemorrhagic strokes of the brain are most commonly in this straight portion of the middle cerebral artery. And the end branches come off vertical at this part of the brain. So if you have high blood pressure, these things can blow out. And these structures here are known as the basal ganglia. These patients will present with immediate gait disturbances. So this high pressure hemorrhagic strokes occur most commonly here, aneurysms here. This is an image that's taken from an MRA, a magnetic resonance angiogram of the brain. And here you can see this is a side view. This is the internal carotid artery coming up into the brain, feeding the front part of the brain. The vertebral basilar arteries coming up through the foramen magnum, feeding the back part of the brain and the cerebellum. So two distinct circulations feeding the brain. If one fails, potentially the other one can take over. And so what we have is we have this anastomosis of the back circulation and the front circulation, which is known as the circle of Willis. So there are communicating arteries between these branches, the posterior, the back circulation, and the front circulation, that enables the brain to survive some major strokes. You know, a person like Ram Dass, who had a major stroke, you know, and has actually thriving with some motor deficits, it's because portion of his brain was revascularized because it had blood flow from another part of the brain. It also points to the fact that there's a significant amount of reserve in the brain. And here you can see it from underneath the brain. We're looking down. This is the posterior, the back circulation. This is the front circulation. And this is a CAT scan angiogram as opposed to an MRI angiogram. And you can see how elegant we can see with our imaging studies nowadays the vascular integrity of these structures, which is going to be really important when we talk about stroke and how to treat stroke both from medical and Ayurvedic perspective. And no, we're not going to talk about using leeches. So I want to just quickly talk about the microscopic portions of our nervous system. And this is the workhorse of the nervous system. This is the neuron. And the neuron is made of a cell body and an axon and terminals both at the top end and the bottom end. So at the top end, they're called dendrites, and at the bottom end, they're called axon terminals. And when they connect with another adjoining neuron or another organ or a muscle, those junctions are known as synapses. And the way they work is that at the end of each one of these terminals are little bubbles of chemicals that are released that cross the synapse junction and hook onto receptors on the opposite terminal and activate the next neuron. Those chemicals are neurotransmitters. And neurotransmitters are very important chemicals. An important study that was done by the Alzheimer's Association, and we'll get to when we talk about Alzheimer's disease, about how to use Kriya Yoga mantra to decrease your risk of Alzheimer's and increase your telomerase activity, involves the science of neurotransmitters. The most common ones are acetylcholine, which are inhibitors, GABA-aminobutyric acid, are known as GABA, glutamate, dopamine, norepinephrine, are all neurotransmitters that you'll hear about them. And they work at both ends. So the axon terminals would be touching the dendrites of the adjacent neuron. What's equally important about the anatomy here is that more than 90% of our neurons have these little structures around their axon sheaths, and these are known as myelin sheaths. And myelin is a really important chemical because it does two things. The first thing that it does is that it prevents cross-circuiting of neurons. So electrical activity that travels down the shaft won't cross-circuit with an adjacent neuron. So this produces insulation to the neuron. And what it also does is it increases the rate of transmission of electrical activity along the neuron anywhere between 100 and 1,000 times if the myelin sheath wasn't there. So it increases the rate of transmission and offers protection. Which is why if you have diseases where your myelin is not well produced, like multiple sclerosis, where the myelin is defective or absent or being absorbed by an inflammatory process, you end up with cross-circuiting, you end up with slow progression of neurons, of neuroactivity, which is why, if you take multiple sclerosis patients and you bring them outside on a sunny day, they all pass out because their neural activity slows down so much that they can't move. You have to be careful that they don't stop breathing because their myelin is no longer there to protect the axon. And in the nervous system, neurons are not the only cells that exist in the nervous system. There are astrocytes, which are the metabolic powerhouses of the nervous system. There are glia cells, G-L-I-A cells, which are support, and they provide the immunological basis of the nervous system. They're the oldest people in the nervous system. They're very kapha-like, they're slow. In fact, tumors of glia cells are the slowest growing tumors of the brain, just like kapha people. And there's oligodendrocytes, which are more support structures of the brain. We'll make a quick journey, talk briefly about the cranial nerves. We've already spoken about a couple of them. There are 12 cranial nerves, and they're called cranial nerves because they arise from the brain or the brainstem. The ones that are the most unique are the first and second cranial nerves, which have direct contact with the outside world. All of the other cranial nerves, 3 through 12, have some type of interface with the world. So the first cranial nerve, the olfactory nerve, we looked at its connection with the brain, but its exterior connection produces these fibers which extend into the nasal cavity. And the average person has about 20 major fibers in the nasal cavity, as opposed to other animals like dogs, which have between 200 and 2,000 of these olfactory nerve fibers, which accounts for their increased ability to smell. But this is direct exposure of brain structure, of nerves that are connected to the brain to the outside world. So you can have invasion into the brain through these areas, which is why you never pull out your nose hairs, because you might be pulling out an olfactory nerve fiber by mistake. The other one I wanted to just briefly talk about is the vagus nerve. The vagus nerve is the 10th cranial nerve. We'll spend a brief amount of time talking about some of the other ones when we talk about pathology. But the vagus nerve is an important nerve because it's one of the largest nerves of the body. It travels the most circuitous course from its origin in the medulla. And it travels from the medulla down along the neck and the carotid artery, around the heart, through the diaphragm, below the diaphragm, around the stomach, and up into the upper abdomen, where it innervates, the small intestines and the colon. So it takes a long course from the medulla all the way down into the intestine. And all along here, it has different functions. In some spots, it functions to regulate the heartbeat and the blood pressure. In some spots, it regulates the contractility of the heart, the volume. In some spots, it controls contractions of the stomach and secretion of gastric juices. And further down, it controls the pancreas, small intestine motility, and reabsorption in the large intestine. So it's a very important nerve, and it runs a long course from the medulla to the colon. And it also has a parasympathetic component to it. So it has an active component and a parasympathetic component. The parasympathetic nerves of the cranial nerves are the 3rd, the 7th, the 9th, and the 10th, the most important being the 3rd and the 7th. But there is a parasympathetic component to the 10th. Which brings us to the parasympathetic and sympathetic nervous system. The autonomic nervous system is important because it's involved in our stress response. And, modern man today, stress is the etiology of most disease. And if we can control our sympathetic nervous system by parasympathetic balancing, then we can probably control and increase our resilience to the manifestations of stress. It's been clearly shown that yoga, that pranayama, and meditation increase parasympathetic activity and can improve resilience. Now, we're going to have stress, Ayurveda works on the side of the stress equation where we can rebalance imbalances so that we don't create stress, and yoga, meditation, pranayama work on the resilience side. So the sympathetic nervous system arises from the thoracic spine. So from T1 through T12, is your sympathetic nervous system. And it, does everything you would expect it to do in order to prepare you to fight, flight, or freeze. It dilates your pupils, inhibits salivation, it opens up your airways so you can get better breathing, shuts off your digestive system because you don't need that when you're running away, increases your heart rate, increases your contractility of your heart, produces glucose from the liver, relaxes your bladder, contracts your rectum. So you want to keep a tight butt when you're running away from that saber-toothed tiger. Parasympathetic system arises primarily from the 3rd, 7th, 8th, and 9th cranial nerves, the oculomotor, glossopharyngeal, vagus, and also the lumbar region down here. So it does the opposite, primarily, this facial as well, as the sympathetic nervous system. So it constricts your pupils, it increases your salivation, it decreases your heart rate, constricts your bronchi, it stimulates your digestion, it stimulates your gallbladder to contract, and dilates your peripheral vessels, relaxes your rectum, and causes Shukra preparation for pleasure. So you can see that these two systems work in constant release charges to balance out the stress response. So we've talked a fair amount about the brain. We talked about the cranial nerves. We've talked about the upper cervical spine structures in the medulla, and we haven't talked about the spinal cord, which is a significant portion of, the nervous system. The spinal cord, it runs, from the level of the brainstem and foramen magnum to approximately the level of L1 or L2. So there's no spinal cord below the, first or the second lumbar vertebral body. All that is on nerve fibers. It's called the filum terminale. Looks like horse's hair. There are 8 cervical nerve roots. There are 12 thoracic, 5 lumbar, 5 sacral, and a variable number of coccygeal, depending on the person. But people say, well, how could there be 8 cervical nerves? There are only 7 cervical vertebrae. Well, there are 8 cervical nerves because the cervical nerves exit above the vertebrae of their naming, with the exception of the 8th. It comes out below. Then every other nerve exits below the vertebrae of their naming. So the first cervical nerve comes out above C1, but the first thoracic nerve comes out below T1. So anatomically, it changes at the level of C7, C8. And so that's just the way it is. And if you look at a cross-section of the spinal cord, there is a front portion and a back portion. So this would be the front side, this is the back part. And the front part, or you can see here, which is the anterior portion, versus the back part here, which is the posterior portion, which is the dorsal root, controls motor and controls sensation, or afferent and efferent fibers. Afferent meaning active, efferent meaning feeling. That'll be important when we talk about the musculoskeletal system and afferent and efferent nerve fibers and how they work for muscular contractility. So the afferent fibers affect and the efferent fibers feel. Afferent fibers, bring information from the spinal cord to the structures, and efferent fibers bring information back from the structures to the spinal cord, sometimes staying in the spinal cord, sometimes traveling all the way to the brain. Information like a reflex, where you take your reflex hammer, and, you hit your elbow. That would be information that stays in the spinal cord and never makes it up to the brain. But if I hit my elbow against the desk, that efferent fiber is going to tell my brain that I injured my elbow. Okay. Before we go any further, and I think we're approaching an hour, one area that I think we should just briefly talk on is assessment of patients with neuropathy. And I'm sorry I'm moving through so fast. If we had the weekend together, I would have had the opportunity to move a little slower. With the incidence of obesity increasing in the United States to epidemic proportions, the incidence of chronic medical diseases is increasing at a steady rate in parallel to that. And the most troublesome of those pathologic processes is diabetes. And diabetes presents in many ways, but one of the more important syndromes that creates a lot of morbidity around diabetes is peripheral neuropathy. And peripheral neuropathy involves these nerves down at areas where they end, particularly in the extremities. So you'll have people who come into you and they'll say, I have peripheral neuropathy. Well, how can you tell? How do you know they have peripheral neuropathy? What tests can you do? Well, there's no imaging examinations that are useful for that. But there are 3 simple tests that I'd like to share with you that you might want to include in your armamentarium just to, to test out, whether or not you think, your vata is an asti, your vata is a maja, and whether it's a neurological vata or not. The first is something that's known as the microfilament test, and you might not be able to see this, but you can see there's a tiny little filament at the end of this, and it measures about 3 to 5 microns across, and it's a soft filament. And what you do with this test, and it's been standardized over many, many years of testing, is you test the patient's bottom of their foot. And you ask the patient to close their eyes, and you lift up their foot. You can see my foot. And you want to rub this filament in 4 different places. Right here at the arch, at the base of the great toe, at the base of the 3rd toe, and at the base of the pinky toe. So the arch, first toe, 3rd toe, and pinky toe. And you rub it gently. And with the patient's eyes closed, you ask them if they can feel it. And if they can feel 3 out of 4 strikes, they're normal. If they feel 2 or less, they're abnormal. And it usually means a peripheral neuron abnormality. 2 other tests that are equally important which help, determine for peripheral neuropathy is position sensation and vibratory sensation. And vibratory sensation, we take our trusty tuning fork again, and we hit it, and you place it on the bone of the ankle, here, the medial malleolus, and the patient either does or does not feel it. If they don't feel it there, you try it on the tip of the great toe. And if they don't feel it there, they have peripheral neuropathy. And the final test is proprioception test, and that is an upper motor neuron pathology. The first 2 I showed you are primarily small neurons in the lower extremities that have been dying as a result of the diabetic neuropathy. The proprioception test is one that determines whether or not it's connected to the brain. And so what you do is you have the patient pick up their foot and you grab their great toe and you have them close their eyes and you ask them, am I pushing the toe away or towards you? And you push the toe either way, and they have to determine which way it's going. And if they're correct and their proprioception is intact, if they're incorrect, the proprioception is not intact. So that indicates that there's something more than peripheral neuropathy going on, and probably something centrally, possibly supratentorial up in the brain. So I want to just close with a brief anecdote about an interesting pathology that, as a medical student, I remember all of us reading about. And it's an interesting story. You think that the brain does not have a lot of reserve, and of course, the brain is an essential organ. I mean, we can't live without the brain, although the heart can continue to beat. Can you be who you were without your brain? Well, the question of brain abnormalities was brought to a head in the mid-1800s. There was a patient, Phineas Gage, who was born in 1848 in Grafton, New Hampshire, and he grew up to be a railroad construction worker. Many people know his story. And after he left his job as a railroad construction worker. He became a Chilean, went to Chile, he became a stagecoach driver in Chile before his death in 1880. While working on the railroad in Cavendish, Vermont, they were building the railroad up in Vermont, Gage was setting a blast when accidentally a 6-foot-long rod set in stone shot forth and penetrated just below his right cheek and went up through his brain and shot out the top of his head. Came out through his left temporal bone. So it was a clean trajectory through his cheek, through his brain. He was transported to the local doctor, a family practice doctor, and then first to Dartmouth and then to University of Vermont for definitive treatment at the time in the mid-1800s by Dr. Harlow for treatment. And after closing the wound and subsequent infection, he lived another decade. But he was incredibly different after the injury. His personality changed, his emotion changed, his relationships changed in a profound way. But he still was able to do, upper level functions. He still was able to do discernment. He held a job. He subsequently died, from other unrelated causes as a Chilean stagecoach driver. So kind of an interesting story. I think I'll stop there. Because there are a number of things I want to connect in with the next couple of lectures, special considerations, things about, how does clairsentience work? Where does that arise from in the brain? What is the etiology of pain, and how does pain work with the brain? And what is the mind-body connection? How do we now understand how our psychology can become a biology, and how we can reverse that by making our psychology undermine our biology. And we know that through Ayurveda. So I'm not sure how to open this up for questions. Oh, chat.
Yeah, you can just open up the chat, or people could speak up if they'd like to at this point as well. It's good to get the questions in the chat box because then the other people can see that as well. So does anybody have questions?
What was the patient you bring outside who passes out? That's MS. What part of the brain is affected by stroke? That's a really good question. And, the most common location for stroke is that area I pointed to in the basal ganglion. But any part of the brain can be affected by stroke. And since most of the blood flow comes into the brain through that front circulation, through the anterior cerebral, middle cerebral arteries, it's in that distribution for the most part. Ram Dass's stroke was in the middle cerebral artery on the left side, which is why he presented the way he did. So it's the most common locations. What are the best ways to increase attention and focus? Okay, really, really good question. There's an article that came out, probably about 3 or 4 years ago. The director of the Alzheimer's Association is a Sikh, and his name is, I'm blanking on his name, Dharma Khalsa. And what he found is that doing repetitive motions, aligning mantra with mudra, that increases attention and focus. And the one that he did most of his research on was satanama. And the way you do it is you hold your hands, and the sa is the index finger and thumb, ta, na, ma. sa ta na ma, sa ta na ma, sa ta na ma. And he did several years of research doing this mudra and mantra and found that the incidence of Alzheimer's disease in the population of people who did it was lower, and the telomerase activity in those patients was much higher than the average population. So it's sa ta na ma, sa ta na ma, and it'll increase your attention and focus, and probably increase your telomerase activity. I can. I'll email. How about I email it then? Can I type it here?
Yeah, you can type it in the chat box. There we go. Betty just did it for you.
Na ma with the mudra.
Did you send that to everyone?
I think it did.
Betty wrote it out anyway, but I don't see yours showing up.
How would I know if it went out?
Yeah, sure. You just hit the button and
I think it went out now.
It just popped up.
Yep.
Yeah. Okay. Very good. There was a question just before that one, Gerard. Somebody asked, what is the second brain, the emotional one?
The second brain. I'm not sure I understand the question. The part of the brain that controls emotion is, well, the little brain. Emotion is in the hippocampus mostly, and the amygdala, which is in the temporal lobe, and there's a component in the cerebellum and the thalamus. So, the reptilian brain is really base functions, like respiration, heartbeat, contractility, those kinds of things. The neocortex are your executive functions. So that's, discernment, personality, creativity, those things. That is one of the reasons that we do Nasya, is to improve brain health, because it's a direct connection to the anterior portions of the brain. And I show that anatomically. You could see those, those fenestrations are right in the frontal lobe.
Any more questions from anyone? Oh, a couple more here.
The mudra you do is you touch your thumb to your index finger. So that's the sa, that's the ta, na, ma. So it's that type of mudra. You're welcome, Terry. That's a really good question. Serotonin is one of the most important neurotransmitters there are. And the brain produces probably about 40% of the body's serotonin, and the gut, the enteric nervous system, which I really didn't talk about much, probably produces close to 40 or 50% of the serotonin. So serotonin is a mood elevator. And the lower the serotonin levels, the more likely you have depression. So if your gut is unhealthy, your brain cannot produce enough serotonin to prevent depression. So gut health is really important. And you see that when people heal from inflammatory bowel disease or IBS, their emotions level off. They're just happier. Really good questions.
Yes, these are great students. Oh, we've got another one up. What can we tell patients 1 to 3 things to do?
To do for what? Okay. You know what? When we get to the section on dementia, I have a whole list of things that we do for brain health. You know, I mean, the obvious ones are, you know, good quality food, exercise, and then exercising the brain in several different ways that we'll talk about.
Cool. So you did talk a little bit about what you're going to do at the next webinar, Gerard?
Yes.
Okay. Very good. Well, if, oops, you got another question. I notice if people have too much salt, it affects the focus. That's rough.
Yeah, that's a good question. When I was talking about the PONS and that syndrome known as central pontine myelinolysis, that disease is primarily caused by sodium imbalance. And if your sodium is imbalanced, it affects the PONS, and it can create insanity. It can create all sorts of problems, including seizure disorders and death. So sodium imbalance can affect neurological things in a really profound way. And in my 34 years of clinical practice, I've had 2 patients who's died from central pontine myelinolysis.
Okay, well, it looks, if there are any other questions, get them up now. Otherwise, we'll close the session.
You're welcome.
We will see Gerard next Wednesday night at 8 o'clock, 8 to 9:30 again. And then the following Wednesday as well. So any questions that you have, you certainly can send directly to him. And then the next, webinar, he can try to address them as well. Thanks, everyone. I will close the recording and I'll get this posted up for everyone.
Thank you, everyone, for being here, for being attentive, for the great questions, and for being wonderful colleagues and good friends. Namaste.
Namaste. Thank you, Gerard. We love you.
Love you all. Bye.
Nice to see you.
Hey.